it's important that we get the feedback. It helps us to shape the agenda, but it also helps us to learn what we did and what worked well and what we need to improve on. And so let's see how we go then. As I've said already, don't forget you can always use the chat function to ask any questions. Next slide. So the feedback from our last meeting was fairly positive. There's a couple of things we need to learn from that, but I think, we've listened to what you've said and see if we can get that right in the future. But the agenda you said was followed and the correct timings were allowed for the presenters and the questions. So it felt like it was well balanced, I think. What message was back from them. People valued that. It didn't feel rushed and it didn't feel like, there was too much time spent on any particular subject, but it was well timed event, and people felt like it was measured and helped them to understand what the agenda was about and what was being discussed. And then the comment, though didn't express any views, it was easy to do so. The process and again was well handled. To give people a chance to put their hand up if they want to, as I've said, or to write a question in the chat box if that's easy for yourselves, recognising that not everybody wants to be seen or heard to ask the question, and that's absolutely fine. There's no problem with that at all. In the local updates from Newcastle and Gateshead, we felt it needed to be focused on more than just COVID-19, with more opportunity to interact, and we've learned from that. There's not on this occasion an update from either Newcastle or Gateshead. We want to spend this session with Joe Corrigan's going to join us to talk about the changes due to the Social and Healthcare Act 2020, what that means for clinical commissioning groups, what that means for the NHS generally, and how we need to refocus how we're going to be working. If that was more important. But our plan will be that there'll be breakout sessions going forward in the meetings post-April, where they can spend more time at that breakout session on either Newcastle or Gateshead place, and people will be able to choose which breakout slot they want to go on to. So the meeting will start off as a shared meeting across the CCG and then split into place-based arrangements and come back together at the end of the discussion. Felt there was need for a clear brief for speakers, and there seemed to be confusion around who the audience was and how to pitch it right. And I think that's a really valid point. We do need to make sure it is pitched right, not too low, but also not too high. And mindful that we try to not use acronyms, and if they are used, I do agree, but we should make sure we always explain what those acronyms stand for and how they're used. There's often acronyms that we all mix up because they're very similar. One I'm constantly mixing up these days is LFT, which most people call now a lateral flow test for COVID. I still, as a clinician, think of that as liver function tests, as a blood test we do, and it still always is the first thing I think of when I hear the word LFT. We have to stop using acronyms where we can. That's important to make sure we get the right message and accurate interpretation of what's said. That's fine. Yes, move on, please. So engagement update, there's some significant changes in the patient and public involvement team occurring over, the next month or so, certainly by April time. Lindsay's moving into a different role in the CCG, broadening horizons, getting a different type of experience, and we wish Lindsay well in that. We know that whilst Lindsay is going on the 1st of April, because Christian's on maternity leave and we have a gap, the new people we're aiming for them to start on the 1st of April. Lindsay has agreed that she'll help to support them into the new role. So there's no big gap, and we can learn from the past and be able to have a formal transition and induction into the organisation, which will start, as I said, we're aiming for the 1st of April. 2 new members of staff have been recruited. One to cover Lindsay, full-time permanent, and one to cover Christian's the rest of her maternity leave. And so we'll see how that works out and hopefully learn from that. I'm keen to try and expand the number of staff in the team going forward. Clearly I won't be here, but I believe in a legacy, hopefully, where people can hear what I've said and share information about the experience we've had to increase the capacity in this team, because I think, there's a lot more we can do and offer, but we just need some capacity to do that. Christian's due back from maternity leave in July, so again, that's something to look forward to. And I know she's ready to come back to work already. She's keen to get back to work and start to get involved in what's been going on. And as you've heard at the beginning of the meeting, I'm retiring on the 16th of March. Technically, my last day is the 31st of March, but I've got a couple of weeks holiday at the end of that. And Julia Young has been appointed. She's currently the Director of Complex Care. in the CCG and urgent care. She'll be taking over as the Executive Director of Nursing, Patient Safety and Quality as of the 1st of April. I've started already to hand things over to Julia. Unfortunately, she's on leave this week, so she couldn't join us today, but she will be at future meetings going forward, and she did join us at our meeting in February. So, move to the next slide. So we've held 2 successful engagement events during February in partnership with Northumbria University. We spoke about these events on a couple of occasions now. One was about the frailty pathway, and there was 10 members attended that session. I think it was, there was good discussion, and people felt it was a useful session to be on and were listened to and able to participate in what was being said and contribute to that. And then the session on enhanced care for older people, workforce competency framework, and again 10 members attended that session, which was again good conversation, useful conversation, agreeing what things need to look like going forward and learning from experiences we've had to date, which I think is important. And both of them had breakout sessions which were used, which again give good feedback. We've learned about the use of Teams. We weren't really sure how to use breakout sessions on Teams now, but we've learned how to do that. So it should be a seamless approach in the future to be able to split the session into more than one breakout group. So we'll get the benefit of being able to do that in the future. Next slide. And important work still continues with the British Sign Language communities and GP practices to ensure services are accessible and we're communicating in the most effective way. We're learning all the time about this and sharing that learning with our GP colleagues and practice staff, reception staff, practice nurses, healthcare assistants, as well as the GPs themselves, to make sure we can make it so it's much more engaging for people who use British Sign Language as their method of communication, as their first language, if you like, to make sure they can be heard and get their voice listened to and influence what happens in their own healthcare. It really is an important piece of work that we've spent some significant time on purposefully to get this right. Because I think it has been an area where we've neglected in the past and trying to make it so that it is a usual and a normal way of dealing with things, not having to be something consciously about making sure we always engage with people who use British Sign Language. The Mental Health Transformation Co-Production Works commenced in Newcastle, but it's also commencing in Gateshead. We're looking to learn from what we did with Deciding Together, Delivering Together, how we learned from that, what we listened to from our public, from our service users and carers, and how we can get that back into frontline service delivery out in the community and transforming the community-based mental health services. These will be based on in Newcastle on the 4 localities and in Gateshead on 5, which is around the primary care networks, so that we can respond to the needs of each of those primary care networks in a different way to meet the population needs, because they're all very different populations in each of those primary care networks, and it's important that we recognise one size doesn't fit all, but we need to make sure that what we do offer is, it's equal opportunity for all those people living in those networks, living in those locations, to make sure they can access what they need to meet their own mental health and well-being requirements in a way that means the service is, delivered to a high standard. It's been a challenging programme of work. There's a lot to do, and we really are now getting this moving. This next year we've been successful. It was a significant bid for finance to NHS England, and that, to be honest, that's been one of the factors that slowed us down, was around the capacity and the financial requirements to move this agenda forward. But we've really managed to do that now, and with some significant, you remember from the past discussions we've had, capital investment into some of the estate for mental health services, particularly the St Nicholas's site and on Northgate site for our colleagues with a learning disability. So again, the services and the facilities be much more akin to what you'd expect in a modern day facility, with ensuite rooms and much more open and environments, much more clear and airy environments than we've had in the past, and we can definitely see that's starting to happen. See some if you like, some tools going into the ground to start those foundations, get those work off. Not every building will be brand new. Some of them will be adaptations from the current buildings, but there will be modern purposely adapted to meet the current needs of modern day mental health practice. Next slide. Is Joe on the call yet? I don't think he's joined us just yet.
I have, Chris. I have.
Oh, hi, Joe.
Hello, everyone. I'm just off camera because I'm having a nice cup of tea while I'm listening.
Oh, no, it's fine. It's fine. Well, I'm just going to do one more thing, Joe, before I hand over to you, if that's all right.
That's absolutely fine, Chris. I'm just, like I said, I'm enjoying a nice cup of tea at the minute.
Yeah, that sounds a good idea. I'm going to have one with you, so that's all right. I wanted just to say, really, are there any questions on what I've said up to now? What we do try to do at the beginning of each of these sessions is give you an update and a flavour of some of the things we do. And it isn't everything we do, because that would take too long to go through everything in each meeting. But we do try to keep you up to speed of what's happening in our main areas of engagement. Are there any questions before I hand over to Joe? No? Okay, so I'll hand over to Joe. That's great.
Hi, everyone. Hi, everyone. I'm Joe Corrigan. I'm Chief Finance and Operating Officer at the CCG. Now, I've got some slides to share with you. So, Lindsay, are you going to drop this one and I'll share my slide deck? That sound like a plan?
Yeah, I'll do that now. It's just taking it down now.
Yep. Okay. Right, there we go. Hopefully this will work. Is that can everyone see that?
That's great, Joe. That's perfect.
Yeah, fantastic. Okay. So thanks everyone for inviting me just to share some slides and thoughts and give you an update on this policy document around integrating care and the next steps for the service. I thought, and forgive me, just I've just dropped in some slides just by way of context and some sort of preamble to the update that the intend given. So for me, in terms of the points to cover, something around commissioning, because the whole purpose of the document, or one of the prime purposes of the document, is to reconfigure how we commission services. So I thought it would be helpful just to share some context and processes. In terms of the commissioning architecture, again, just to share some of our ways of working that will hopefully give an insight into why these changes are being proposed and how they are to be adapted locally, because the policy document is quite permissive. It does talk about, now we'll come on to, about integrated care systems, but within that, the proposed policy framework and legislation is quite permissive. And then I'll just finally just conclude into where we're at in terms of implementing ICSs and some of the changes set out in the document. So hopefully that will work for everyone, and do forgive me, I've just pulled together some slides, some of my sort of favourite slides to set the policy context. So hopefully, the will also work for you. So firstly, in terms of...
Sorry about Joe, sorry to interrupt. Some people say they can't see the slides. I wonder if there's something we can do about that. I don't know. Or it's something you're doing, Joe. Alison can't see. Anybody else?
Lindsay, shall I quickly email them to you?
Yeah, I could email them out to the group. So they've got them on the email, or
could you upload? I don't know whether it's my device or.
Can everybody else see, or is it just?
It's a shame. It's a shame if everyone can't see it.
Yeah, everybody can see them. I think there's only Alison who can't. Joe, if you share them with Linda, she'll send them out by email, because otherwise we'll risk other people missing out on them as well. But make sure everybody gets at least a copy on an email.
So I'm afraid, Alison, you're just going to have to listen to my voice. So forgive me on that one, but we will send them out. Okay, so in terms of commissioning process, I quickly canter through a couple of slides. What is commissioning? It's a circular process around needs assessment, and increasingly, and rightfully so, this is more holistic needs assessment rather than health needs assessment. And this is often driven by our work with the local authorities and the joint needs assessment that we do with the local authorities. So once we've identified patients' communities' needs, we need to design a service that meet those needs, or if there's an existing service that's not quite meeting those needs, we need to redesign that existing service. We then need to put in place a contract, and what the contract in essence sets out is the rights of the patient and the liabilities for us as a commissioner on the service provider. So it's a traditional contract mechanism, but importantly, it sets out what the patient should expect in enjoying the benefits derived from the services that's being provided. And as ever, we should review as to whether we're actually meeting those needs that we intended to set out to meet in the first instance. So quickly, that's a rattle through the commissioning process, because there are some significant changes proposed in relation to some of those components of contract commissioning, primarily around contracting, and I will come on to that a bit later. In terms of this, I like this heat map around the inequalities, and particularly we can see in the north and the northeast just how much inequalities we do suffer compared to the rest of the country, particularly the south of the country. And this is another sort of heat map. 9 of the 10 poorest communities in Northern Europe exist in England, well, 8 in England, 1 in Northern Ireland, and that for what is probably the 6th, I think now will still remain as the 6th richest economy, is quite stark in terms of the inequality between those who have and those who have not, in England, in our country. So I do like that slide, because, as I say, it really is a sobering slide. In terms of some of the changes, what this slide just articulates quickly is how funding is allocated from Parliament to the Department of Health, to NHS England, and then to us as a clinical commissioners group. NHS England keeps some of the money to contract directly for primary care that they've now given us to contract for. And NHS England keeps some money for commissioning of specialised services. The CCG, with our money, we commission hospital services, mental health services, and community services. So already I'm painting quite a picture of a complex funding flows within the NHS in terms of trying to commission integrated services. So you can imagine what the policy document is trying to simplify. One of the things it's trying to do is simplify the funding flows and funding streams in terms of commissioning these ranges of services. This bar chart, I really do like, because it shows the relative spends across each of the financial years, certainly that we've been in existence, but also across the various service types. So what it really does shine a spotlight on is the amount of money we actually spend on hospital-based care. It's a very expensive type of care. Yet in terms of primary care here, 1 million contacts happen every day in primary care across England. So there's lots of activity here. There's less activity here, but it's more expensive activity. And we can see, Chris talked about mental health services. Over the years, it's been relatively flat. We're now seeing slightly increased investment through the Mental Health Investment Standard. But really, the narrative around this slide is just how much of the relative spend is applied across the various parts of the healthcare system. In terms of the commissioning architecture and our ways of working, this slide just really shows the relationships between the various bodies that came about from the introduction of the the other changes from the last legislative changes with the NHS in 2013, and it's actually a relationship diagram with all the various bodies that were introduced or came about with the introduction of the last legislative changes. It looks like a circuit diagram. It really is complex, and there is us, a clinical commissioning group, and we can see all of the various relationships we've got with the different parts of the system. Again, this sets some of the context as to the changes within the proposed legislation that's come before Parliament over the summer and the autumn. This may be familiar to you, and I'm really getting to the crux of some of our ways of working and proposed changes. These are two diagrams that you may have seen from the consultation document locally around our integrated care system. Chris, I just caught on the call when Chris talked about commissioning services for people, and very much at a neighbourhood, a primary care network level, we can commission services very much for the local communities, whether it's St Chad's in the middle of Bensham, or the communities in St Anthony's in Walker, or West End Family Health in the inner western Newcastle. Very much community-based commissioning at a local neighbourhood level through our primary care networks. We then come into another level of commissioning with our local authorities, on a Newcastle city footprint and on a gated council footprint, very much on those type of geographies that really do integrate with the care services offered, particularly with the local authority. We then come into the ICP level of commissioning, the integrated care partnerships, and we can see within our ICS we do have 4 ICPs. It's not important that you can read the text in the in the boxes. I just included it simply because I wanted to get the map of the ICPs within our ICS level. So in terms of ICPs, sub-regional, so we're part of the North ICP, where we've got Northumberland CCG, North Tyneside CCG, and Newcastle and Gated CCG. And again, particularly around hospital-based services, if we think about how we're going to commission hospital-based services, particularly urgent care services, they're no longer particularly hospital-based. We now think about urgent care services across this type of geography. So how Newcastle hospitals, it does support a regional role, but how Northumbria Healthcare, Newcastle hospitals, and indeed gated hospitals can all work together, particularly to support the urgent care agenda. At a next level up footprint, our ICS. So this is our entire ICS. There are a range of services we need to think about delivery at an ICS level. These are particularly cancer services or very much specialised services where every hospital couldn't provide them. They're too specialist. The clinicians wouldn't develop their specialism because they wouldn't see enough patients. And particularly Newcastle hospitals do actually provide a super regional role and a national role in some of the services that they actually provide. Very specialist services, for example, cochlear implants, cleft lip and palate services, some of the cancer services, some of the immunology services, really specialised, that actually there are only 1 or 2 or a handful of providers nationally who provide these services, and Newcastle is one of the national or one of the biggest national providers of specialised services across that full range. Just as an aside, I don't know whether people picked up, but it was in it was announced that one of the top 200 hospitals in the whole world, which is absolutely fantastic. But as I say, there's various levels to the commissioning of our services depending on what type of services. It's no good, for example, us commissioning community services at an ICS level. They just simply wouldn't be sensitive enough. They wouldn't be sensitive enough to those families and people's needs within our community. So hopefully what this has articulated is at various levels, depending on what the types of services are, we commission at the various levels that we do have within our ICS, right from the ICS, the whole geography for Cumbria and the North East, right down to communities and neighbourhoods through our PCN arrangements. Lindsay and Chris, I hear my phone going, so I cannot see the chat. So if anyone has a question or has got their hands up, or can you just help me out here, and I'll try and do that because I cannot see it on my screen. Fantastic.
No questions at the moment. It's just Chris explaining ICS and ICP.
Great. Okay. So with that in mind, by way of context, we're coming round to the integrated care policy document, what's being proposed and where are we as an ICS and as a CCG to support implementation of the policy document. So in terms of the intent, the document was first published on the 26th of November last year. It proposed policy and legislative changes to accelerate the development of ICSs. We have been working with our ICS for quite some time, and we forget that the whole country does not have an ICS way of working. And so clearly what this policy document was saying that by April 2021, the whole coverage of the country in terms of ICSs rather than, the predecessor SDPs was the way forward. So there was the clear intent that this document enabled that to happen and actually accelerated the ICS working across the country in terms of the way forward. And having put those in place in shadow form by April 2021, the expectation was that the centre, the NHS, would receive each of the ICS plans by September. In terms of the policy ambitions, there were three policy ambitions and also something specific around the use of digital. So in terms of the approach to commissioning, the first policy the ambition was around developing strategic commissioning through systems with a focus on population health outcomes, and again supporting those population outcomes and that thinking at the various levels. Stronger partnerships in place between the NHS, local government and others, large role for the voluntary sector, with a more central role for primary care in provided joined up care. And the third area was around provider organisations being asked to step forward in formal collaborative arrangements that allowed them to operate at scale. So each provider, each hospital and each mental health provider had to be part or has to be part of a provider collaboration. And this cements part of the architecture that I talked about earlier, where providers need to work together because of clinical networks and the configurations of some services like urgent and emergency care services that really cannot no longer be provided on a single hospital. The hospitals, the interdependency between the hospitals going forward is going to increase simply because of sustainability of services, clinical networks, and there are particular service areas where that holds more so than others. So again, huge strength in provider collaborations going forwards in a way that we haven't seen for quite some time, certainly since we've had the internal market, and there's been a whole emphasis change around cooperation rather than the competition way to service delivery. And the final element is around the use of digital and data to drive system working and connecting healthcare providers, improving outcomes, and putting citizens at the heart of their own care. So those were the four main policy ambitions within the proposed white paper. In terms of commissioning itself, and the document is clear that commissioning is a function that will continue for a number of reasons. It's some of the contracting components of the commissioning cycle that will see significant changes for the better. Okay, so firstly, in relation to the first of the three areas, a single system-wide approach to strategic commissioning, and this will be at the heart of how the ICS will discharge its functions. And again, get back to that commissioning cycle around assessing population need and planning and modelling services according to those needs and how those will change over time. Planning and prioritising how the ICS and its various substructures will address those needs and improving health and tackling inequalities. Again, going back to some of those heat maps that I showed you in by way of context, and ensuring that these priorities are funded to provide best value and best outcomes for our population and the patients that we serve. The second ambition area in terms of commissioning, service transformation and pathway redesign need to be done differently. And again, this leans into provider organisations operating in a collaborative rather than a competitive way, and that being the future way in which the service will provide care for our patients, and through a greater public transparency and accountability. There is a nod in the policy document around clinical leadership and how that has certainly served CCGs well and is crucial as part of commissioning arrangements going forward. And the final area, with the greater focus on population health and outcomes, is how we can align those financial funding flows that I talked about earlier, how we can create a single pot, or rather have those several funding flows and streams, have a single pot of money and a less burdening approach to contracting. Those who have been in the service or have been a party to an NHS contract, it is a very burdening process for a number of reasons, and one of them is, or a primary reason, is around EU procurement law and the need to procure services. And now that we have a free trade agreement, the government is signaling that it does not wish the NHS to be part of those contracting process or procurement processes going forward, and moving to a position where contracting authorities can simply place a contract without going through a huge process or a burdening process around procurement. And having been part of that, I must say that is a most welcome development or proposal within the white paper. Okay, let me flip on to the next slide. So I've just thought bring this slide back up again just to make the point that instead of all of these funding streams, the ICS will have a single pot of money where it can determine without constraints of a funding stream how much specialist services it needs to commission, primary care, hospital services, etc., etc. Next steps. So I've already touched on every system needs to have an ICS by April 2021. We will also need to ensure that there will be those plans in place, setting out how by September 2021 the ICS will propose to discharge its functions around population health management and the priority needs of each of the ICSs, because they will be different across the country, and how the commissioning functions will be underpinned by constitutional arrangements within each of the ICSs. It gets back to my earlier point. The ICS is the framework, but each of the ICSs will have freedoms within the framework. I've already touched on those things. It's also clear within the document that the COVID-19 response hasn't gone away. So whilst what we're trying to do is build an architecture that's fit for the future, there's nonetheless there remains immediate work around the COVID-19 response. So that is the last of my slides. In terms of our own ICS, we are currently, now that the chair of the ICS has been appointed, Professor Cillian Donaldson. Clearly, work is in train to develop our own plan for the September submission. In terms of some national and regional work, the centre is currently mapping out of our 227, I'm not quite sure, or can recall 227 or 272 functions of a CCG. How will they then map into ICS arrangements? So that work is continuing, and we're very much in a place at the minute where we are defining the responsibilities at those various levels, at PCN level, community neighbourhood level, through to place-based levels. And again, policy documents clear about the primacy of place, so the place-based footprint based around local authorities. ICP levels, again, primarily driven by the need to configure some clinical services at larger footprints, and then building up to the ICS footprint in terms of specialised services, how those are configured and commissioned, and predominantly around population health management at a scale, across northeast and North Cumbria. And there are again approaches to population management at that level have proved immensely successful. If you just think of Fresh and Balance, the anti-smoking and alcohol awareness, those types of programs have really had some traction when they're delivered at a sort of regional basis. So hopefully that has give you some insight as to the rationale for some of the changes, some of the benefits, and quite where we're at in terms of the development of our ICS proposals. It's very much sort of early stages, and again, I think now we've got Professor Cillian Donaldson in place, and clearly we'll start seeing things emerging in terms of how the ICS architecture and arrangements will evolve. Shall I stop there and take the presentation down so I can see everyone and just invite questions? Yeah, just bear with me a tick.
It's Chris coming back in just a second. So we've got one hand up here already. But Judy with a question.
Thank you very much. That was really interesting. I have a two-part question on specialized commissioning.
Mm-hmm.
First is an economical question. Surely specialized commissioning is specialized because we don't need one in every area. So I'm not sure how that's going to work. And the second part is, how will local, this region in particular, deal with the 13Q duty of specialized commissioning?
I think just as there's lots in there. Just as we talk about the strategic shift from secondary care to primary care, there's also levels of shift from specialised services into secondary care. We talk about tertiary care services into secondary care services. So some of the big centres like Newcastle, if you have a problem with a hip, it may be a simple problem, or maybe a complex problem. But if it's a simple problem, you'll probably see the same clinician who will also see those complex problems. So again, there's something about within Newcastle hospitals or the major tertiary centres, how they deal with what are, in essence, secondary care presentations versus the more complex tertiary presentations. In terms of the commissioning of the specialised service, you're absolutely right. And again, there's various levels to specialised commissioning, because some of them are regional. And again, at an ICS level, that's absolutely right in terms of commissioning those regional services. Some of them are super regional in terms of the north of England. And again, one of the challenges is that how, as an ICS, can we commission those services for other parts of the north? And I do think that's still to work through, as is some of the services that Newcastle provide. And I picked up in my presentation, there are only 1 or 2 centres around the country who actually provide these services. So I think that's a complexity that, particularly at that more specialist end, that's still being worked through by NHS England. And it may well be there is a blueprint to this in terms of the PCT. The PCT used to commission some of those specialised services. The North of Tyne PCT, or the Newcastle PCT, as it was part of North of Tyne, used to commission some of those services on behalf of other areas. But some of the national commissioning was retained by NHSE, so there may be that model that will retain going forwards. And as I say, it did work well in the past, and that may be something that will continue in the future. So you're right to highlight that's a complexity still to work through.
And 13Q?
In terms of?
13Q, the responsibility of any specialized commissioning body, that whenever there is a change in commissioning, they're required by law to assess the quality and detail of public involvement and consultation before going ahead.
And I think that runs through not just specialised commissioning, it runs through all of our commissioning functions in terms of how we consult with the people that we serve in terms of the services that we do commission. And again, it's a sort of a personal thought that unless we, 1 million people are seen in primary care every day. That's 1 million individual patient stories, and unless we truly understand what those stories are, we will transform clinical services. But if they're not reflective of patients and the patients' needs and how we can support patients, we'll not transform care. So I do think in terms of your whole approach or questioning around how do we involve patients and public in terms of whether it's specialised commissioning or whether it is non-specialised commissioning, I do think that is really at the heart of much that we do in terms of commissioning services, or else we're not going to get it right. I think
thanks, Joe, for that. Any more questions?
Judy's still on. Sorry, Judy, I thought we lost you there. I thought
you had lost me. I had to dial in again.
Okay.
Yeah. Welcome back, Judy. Siobhan, you've got your hand up.
Hello, everyone. It's quite a complex picture, and one of the things that I'm wondering, and we've talked there about involvement of patients and the public. It's an offer really of whether Healthwatch and Gateshead or Healthwatch Newcastle can support in terms of getting some of the messaging around the changes that are happening. So before we can move on to kind of involve and consult, we need to make sure that people are aware of some of the changes, and to try and do that in a way that best meets those people's needs. So it's an offer, but also with a request in terms of making sure that we get the message right and can translate some of the complexity, if you like.
Yeah.
And I'm sure that's enough that Siobhan would want to take up and work with you to do that. It's really helpful that we do that together get the right messages out there, and make sure all of our patients, carers and public have the message of what's happening, what it means to them. One of the things I was going to say really is to plea to Jodie's team really to ask you to come back maybe a couple of months time to update on any progress and how things are starting to spin out and what we've seen the architecture developing as, because I think it's still only very early days today around what's expected, and we're just keen to share with our patients, carers and the public what's potentially going to happen, but recognising it is going to change as we get more detail.
Chris will bear testament. When we talk internally, I often talk about the world through my mother's eyes. Very complex, elderly lady who really does want to maintain her independence, to stay at home, and what difference does it make in terms of the world through her eyes? And and again, it gets back to there's a million patients are a million stories, and unless we listen to patients, as I say, we're not going to transform care. We'll transform clinical services, but we'll not transform the care, and we will not will not touch the point in terms of what will make the biggest impact on their lives. And as I said, my mother's a classic case story.
Yeah, no, that's right. I've heard Joe say umpteen times and given in various places, which is good. Terry, you've got your hand up. You're on mute, Terry. Terry, you're on mute. Terry, can you hear me?
There we go.
Oh, there you go.
I was just wondering what the future is, Joe, for the rollout of some of the telehealth and telecare stuff that came out nearly a decade ago now from the whole system demonstrator and bits like that, and what role the plans for the ICS across the Northeast might include in terms of telehealth and telecare.
With COVID, what we've seen is a transformation in terms of some of the clinical consultations that have been happening, and telecare and digital have played a significant role in that, to the point that actually what is challenging us is those who do not have access to digital methods, or those who may find use of digital technology difficult. So the digital literacy is for us a challenge in terms of just widening that inequality. So to try and answer your question, absolutely, telehealth and digitalization is absolutely a way forward that we need to build on in terms of some of the significant advances in a very, very short period of time that's come from COVID, to the extent we now challenged by how do we care for those that don't have access to such technology or can use such technology. So absolutely a way forward.
Thank you.
Any other questions? I've got a few more minutes if there are any other burning issues or questions anybody might have. Okay, I'll say thank you, Joe. That was really helpful to give us some of the background and share us with where we are with that really important agenda. It's absolutely going to change the shape of healthcare going forward. It's going to make it more impressive. It's going to be more integrated health and social care, which is some of the things we've all been talking about for some time now. This is a real opportunity. We've got to really grasp this. And let's make it happen, folks, is what I said. And I look forward to, well, I'm saying I look forward to, I won't be here, sadly, but I'm sure the CTG looks forward for the next year to working with Healthwatch and others who are keen to help shape this agenda. I shall shape it from behind the scenes, should we say. I'll be having a different role in life going forward. I'll become one of the patient carers in a different form, perhaps.
Fantastic.
Okay. Thanks, everybody. Thanks, Joe.
And I look forward to coming again in the not too distant future.
No, great. I'm sure we'll pass that on that you're happy to do that, because it is an important agenda to drive in this programme of work here. Fantastic. So,
okay, take care, everybody. Take care.
Thanks, Joe.
Pleasure. Bye-bye.
Bye. So if there's no more questions for now, I think it's a good point to stop for our break. We'll just still take 15 minutes still. It's 5 to 11. So if we come back at 10 past 11, are people happy with that? If you put yourself on mute and camera off until we come back, then you can get on, have your drinks of tea and make yourself comfortable again. And see you in 15 minutes. Thanks, everybody. Hi folks, it's 10 past. Everybody back? Okay. I'm going to hand over to Kate now, who's going to talk to us about the information now. Kate, are you there to do that, please? Yeah, I can see you. That's great. Thanks, Kate.
Here I am.
Yeah, thank
hi,
you.
everybody. I'm going to introduce you to the Information Now website. Some of you will be familiar with it, others won't. And I suppose the reason I'm going to talk to you today is because we've done a bit of a design refresh and I wanted to show you around that. So I, just like anyone else, I can't see anything in the chat once I go to my screen. So if Lindsay, you would let me know if anyone has anything to say. So I'm going to share my screen now. Somebody's just letting Adam in. Somebody keeps popping in and out. They're having problems with their internet today. Okay, so hopefully you'll be able to see my screen now. Let me know if there's any problem.
Looks fine, Kate, thanks. Thank
you. So here we are on the home page of Information Now. So Information Now was developed in sort of 2009-10, and it's sort of had 3 redesigns during that period. It's built on WordPress platform because we think that gives the user the best experience when you're trying to search things and try and get a similar experience to if you were using Google. So I'm just going to sort of show you around the screen to begin with, the home page. So here we have where normally it would say register or log in, and I'll explain why that might be worth doing in a minute or two. But for me, it shows that I'm logged into the website as an administrator. Here on the white tab here, we have a software called ReciteMe. Now, this is our accessibility software, and it's pretty good, actually. It's a good standard for across the country. And it's been built and developed here in the Northeast. So we're very pleased to be using this. This is really useful so that, let's say you need to read everything in a different language, or you have visual impairment of some kind. Then with a visual impairment, you might find if you change the background of the screen to yellow and the type into black, then you would see things a lot better. But there's also a ruler. But you can also create an audio file of any bit of the website. So it's a really functionality that we've got on the website. Now here you've got the very typical type in a word here and you'll get a sort of response pretty similar to Google. So I'm just going to do that to show you. So I'll click on dementia because I obviously did that last week. And then it's a bit slow today, I'm afraid. Anything to do with dementia has come up, and we've got 4 boxes. So what we've got here is information that covers the word dementia. Then we've got some of the organisations involved in supporting people with dementia. Here we've got all the online things that are going on for people with dementia. So the Dementia Cafe might be the Carers Cafe, etc. And then where we've mentioned dementia in our newsletters. So I'll just go back now. So here we've got browse by category. So if you're new to the site and you just want to browse around and see what topics and things we've got, this is a really good place to start. So usually when we're all out and about living our more normal lives, this is one of the most hit areas of the website, so leisure and lifestyle. And this sort of takes you to our parks and gardens, our museums, our cinema, anything to do with faith, hobbies, etc. So you can click on one of these and you'll see it goes darker, so you can see that you've clicked on it, or you could just scroll through all the articles that we have here. So music venues, you know, all of the things that might be of interest to somebody. And you can also search again from there if you wanted to do so. One of the new features that we've come up with is popular articles. So every quarter I look at Google Analytics. So that's something that sort of sits in the background of the website, and that tells me what people have been looking at. So obviously the last year has been an unusual year, and events and activities would have been a really high number of hits for us. But these are the articles that people have been looking at in the last year. And it's no surprise, I think, during the coronavirus to find care and support. So that's something to do with what is offered by the council. Attendance allowance, a lot of people are going into more of a caring situation. Care homes in Newcastle and home care agencies. This has always been a big hit for us. When someone dies, a practical guide. But the biggest hit this year has been food banks and emergency food. Actually, you know, I think something like 13,000 hits just on that article there. But then people have been looking at the good health, tips for good health, bereavement and grief, mental health, and the bottle in the fridge scheme. Then if you scroll further down, you can see all the upcoming events for starting today or on today. And then we've got an explanation of how the website works using British Sign Language. We are going to update that film, but Deaflink have been too busy to do so at the moment. So I mentioned to you that it might be worth your while registering on the site. So if you were to register on the site, you get a form to fill in, either as an organisation who wanted to upload their profile onto our site, or as an individual who wants to use the site. So if you become a user of the site, a member, then you can use something called favourites. Now here you can see I've saved my favourite organisations: Chain Reaction, Later Life, Audio and Radio, Newcastle Emergency Carers, and then my top articles I've also saved. Here also is something very useful. So you can save any event on the website, and I'll show you that tab in a moment. And you can save it into your own personal calendar. And what's great about that is you get it in date and time order. But here you see you can email events only. So you can email that to someone. It becomes a sort of document that you can turn into a Word document. You just print it out. And so a lot of community groups just print it out and hang it up in their on their boards in there so people can see what's going on around them. And the reason I mention this is on the events and activities tab, you can search by name of an event, search by location. Now these are wards, which are a city council thing, but you can also search by postcode. So let's say I put in, let me think. I'm just going to put that one in. And the only one that's come up for today is Hodgkin Park. Now, this is because most of our events are online. This one will be coming under outside in nature because this is meditation when you're on a walk. So, you know, you can see that that's really useful. And as I say, under more normal circumstances, people were looking at this section. And I think the joy of this section is this is the free, or you maybe pay £1 section. So all the community groups put their events onto this website, and then anyone can find them and take part. And we created this section in 2017, and it's become a really popular section on the website. I'm going to go back to information now and just show you how an information page works. So here is what you get, but I'm going to show you the 10 tips for good health. So what we've created in the last version that we created in January is that you can actually see the menu. And these are all hyperlinks. So if you wanted to just know something about having regular health checks, you can just click down to that section. If you want to just find the useful organisations, you can see Active Newcastle, Change, Grow, Live. These are all the organisations that are linked to this article. Then you can actually just click down to those and related articles. So these are all the articles that we have said to ourselves fit with the idea of 10 tips to keep healthy. Now, I mentioned that you can favourite things if you're a member of the website. So all you would do here is click on it and you can view favourites, or this would be a plus sign if you wanted to add it. And it isn't, because I probably added it a few minutes ago. And again, you can see you can share any page on Twitter or on Facebook. You can email a page to someone. You can print, you can save as a PDF. And on any page of the website, you can comment on the page. So you can rate the article, but you can also send us a message. So the people who are frequent users will say, hey, Kate, did you know that phone number's changed now? So it's a really, really useful bit of the website where people, I suppose, share with us the importance of keeping it up to date. So I know that the idea of sort of having your main site as a digital site is a bit controversial. But if you think about how important it is that information is kept up to date, you just couldn't do this in a directory. So this has 320 articles of information, and it has about 1,600 organisations, and under normal circumstances, about 15,000 events and activities. So you just couldn't keep that up to date. But what we have done, as I say, is create that opportunity to print any page on the website or email it to someone so that people can keep in touch that way. The other new bit of the website that we did most recently is since about November 2019, I've been doing a regular broadcast with Radio Tyneside that works across Gateshead and Newcastle, and just putting out information that I would be putting out in the Info Now news bulletin. So the idea is to get to those radio listeners that aren't digitally inclined. So if you want to subscribe to the newsletter, you would do that there. Or if you want to listen to the latest podcast, you could do that there. And then this is the latest bulletin here. So this is a sort of archive of them here. And there's a little bit about the information. So for instance, on Friday, I was promoting the idea. It was International Women's Day today. And then on the events and activities, we'll have events for women here. So you can see there's quite a lot going on related to women, but also particularly for International Women's Day. So there's a pop-up choir this evening, there's craft, there's This Girl Can, which is all day today, run by Active Newcastle and This Girl Can, etc. So this website was designed through the Quality of Life Partnership. It is sponsored and supported by both the City Council and Newcastle Gateshead CCG. And it's been quite a success in the city. In Gateshead, there is Our Gateshead. And it works very differently to our website. But at the same time, the idea is to go have a one-stop shop for your city that tells you everything that you need to know. So what was most interesting last year was people did email me to ask me to write a few articles. So that's not the normal circumstance, to be perfectly honest. The food banks one we'd already done in 2019 at the request of the poverty group. But the ones I was asked to write this year were gardening and health. Sleep was a really important one. And to do a bit more on grief and bereavement. They were really important to people this last year. So here you see I've done a little bit on grow your own and microgreens. And the idea of the microgreens section was just to show how much you can do just using your windowsill or a very small little box, and get involved in that way. So just to say, we're always willing to listen to what people say to us about what they'd like to be reading on Information Now. We've got 14 categories of information, and you know, we're always really, really happy to write something. I think the one that I wrote during, the other was section that I wrote during lockdown. I've done one on scams, in cyber scams, because that's been a rising problem over the last year, and also one on low income. So if I just type in, sorry. If I just type in low income here, we've got a section on support for low income, attendance allowance. So all the ones that are sort of probably useful to you. Orange Box supplies free furniture. North East Law Centre obviously support people on low incomes, particularly asylum seekers and refugees. So all of these have come up for a reason related to the word income, probably, or low. It could be either of those. So I think those are the most important things that I wanted to show you today. Does anyone have any questions?
I've got a question, Kate. It looks fabulous, and I think it's so easy to use as a website. So well done, because it does look really good and really useful. And I think the fact that you can personalize it for your own information is fantastic. I noticed a few things on Gateshead. So is there some information in the Gateshead area on this site as well, or is it just mainly for Newcastle?
Right, so there's two points I'd make here, I think. The first is the information is the information. So, you know, if you want to know what's available for grief and bereavement, I'll just sort of show you this as I'm talking. The information stands alone, so we've researched it, and on occasions we will have written it with an expert. So I didn't write the sleep article on my own. I wrote it with someone who is a sleep expert at CNTW. But we've got a few of these little grey boxes at the moment because of coronavirus and what we want to promote at the time. So that's the first thing I'd say. With regard to the useful organisations, many of the voluntary sector organisations and community well, maybe less so the community, but the voluntary organisations work across either the North East or Newcastle and Gateshead. So they would certainly be on our website. So if you were looking here, you know, Cruse is Tyneside, Independent Age is national, Marie Curie is across the North East, but its centre is based in Elsick. So that's kind of the thinking behind what we put on here. So you will find Gateshead organisations because they are the main provider of a service that we think people need to know about. But what essentially happens is that organisations want to come onto the website, they upload their profile, and then we will look at whether or not sort of there is a good reason to put them on the website. So apart from our articles about equipment and aids, where we do have Stannah lifts and we do have Ostara who do telecare and things like that, we don't put product related organisations onto the website. They're mainly charities or statutory sector, and they're there for a good reason because they support some sort of message about information we want to get out. Were there any more questions?
There's no more hands up.
Okay, I'll take down my screen then. Thanks, everybody.
Thank you. It's really helpful, Kate. Very useful. A number of comments about the presentation being helpful. A great presentation. So really useful, Kate. We appreciate you taking the time to do that.
Thank you.
It is really helpful to get that kind of local information, what can be really helpful to people on this group, and that they can share with friends and the people they come in contact with. Next agenda item is our Health Watch update. I'm going to invite Siobhan to do that. Siobhan, I can see you on the screen in the corner. Great. I'll go on mute.
Hello, everyone. Okay, that's a strong presentation to follow. I thought that was really great. Thank you very much. So an update from the Health Watchers, both Gateshead and Newcastle. I'll start by advising everyone that we have recently appointed a new chair for the Newcastle committee, and that is Peter Dean. So the information about his appointment went out last month. And a big thank you to Terry, who's on the call, for holding fort. We continue to engage via social media, and we, just listening to the feedback on the previous meeting around COVID and non-COVID related things. We are one of the organisations that is getting out a lot of the COVID related messaging and reinforcing some of the messaging around COVID and keeping people up to date. But we have tried to ensure that we cover non-COVID related things. So this morning I noticed that we've retweeted the CCG International Women's Day, but we've also put some information out around mental health and well-being in schools, because obviously today is the day that the majority of school children go back, and we know that there are degrees of anxiety from young people themselves and from their parents and carers. So our social media continues to be very important for us whilst we're not able to do face-to-face. We are also running a questionnaire via social media on uptake of the COVID-19 vaccine, and we had some input into that. We're using the Health Watch England survey, but we've tailored that and added in some questions, and that's going to continue running, and we'll continue to feed information from that into the system. We responded to both Gateshead and Newcastle budget consultations. Each of our committees were involved in that, and those went in last month. We still have volunteers and staff members undertaking befriending calls. So we've got 7 people in total doing weekly befriending calls for people who've been impacted by kind of isolation and loneliness as a result of the way that we've all been living over the past months. We've also been working with a number of voluntary community sector organisations, and we're producing a series of videos that we're then sharing. So we've worked with the Josephine and Jack Project, Gateshead Stills for Work, Veterans at Ease are a couple of examples of those. The really big thing for us at the moment is that we have begun our priority setting process for the coming year. So in terms of what we've done, we have looked internally at the information that we've gathered through any of our mechanisms for gathering people's experiences around health and social care. We've drawn those together and we've come up with the beginnings of our long list, but it is very much that internal look. And we have engaged with both the Health Watch Gateshead Committee and the Health Watch Newcastle Committee. We've got committee meetings coming up later on this month, and we will continue with that priority setting process. In parallel with working with the committees, we're also reaching out to voluntary community sector organisations and other stakeholders to get their input into the priority setting process and to get an understanding of what the priorities are for other organisations, and asking ourselves the question around the impact that we as health watchers can make and also if other people are doing work in a particular area where probably they're best placed to continue with that work and we might support it. So making sure that the right people are doing the right things around those priorities. And we will keep everyone up to date as we progress towards our shortlist and then our fixed priorities for the coming year. I think traditionally we've undertaken long research projects, and we've been looking into how we will filter the project that we do, and whether some of them will be long research projects, but also some of them are just about getting real-time information quickly and bringing that into the system so that improvements can be made quickly, and we might take a task and finish approach to some of those things. We continue with our troubleshooting work. So we have worked with a member of the public who raised a concern around their neighbour, and it was around the use of PPE equipment by care workers who were attending their neighbour's home. And we did some work around that, and as a result the care provider has taken action both to make sure that staff members are more aware around the need to use PPE, but they've also written to all of the people who they provide care for, just reminding people of what the PPE requirements are and what they should be able to expect from their care workers. We've also worked on a safeguarding issue that has led to adult social care involvement around a particular member of the public, which I won't go into because that's not appropriate. A couple of things to highlight really. We attend Healthwatch Gateshead attended Skill for Work Zoom session this month to hold a focus group on experiences of accessing GPs and hospitals. Skills for Work support young adults who are 18 to 30 with a learning disability around gaining skills in work, and we got some very positive feedback from that in response to kind of questions around treatment explanation and their experience of services. And at the end of the session, we agreed we would return to discuss the findings, but also to hold a parent and carer focus group at their parents' forum to hear their views. We've also met with an asylum seeker and refugee organisations and are beginning to identify issues around asylum seeker and refugee access to healthcare services during COVID-19. And some of the difficulties, you know, we talked a bit earlier about the way that access to health services has changed, and some of the automated phone and triaging services at GP practices, when they're in English, that can be a barrier to people whose first language isn't English. There's also been some issues around NHS 111 and interpreters, and we may be doing some more work around that. We are looking at some work in partnership with St Oswald's Hospice, and we have also undertaken some work with one of the PCNs that has just come to an end, and we've delivered the report to the PCN, and we'll continue to think about our own approach to place-based working. And we carry on with our signposting service. So we have signposted people to PALS from both Gateshead and Newcastle. We have escalated to the ICA, one from Gateshead and one from Newcastle in recent weeks. And we've also signposted people onto the advocacy centre to get advocacy support. A very quick update from us. I think the takeaways for people are around our priority setting, and if anybody wants to get in touch with me outside of the meeting to hear a bit more about the priority setting, or has a burning issue that they think should be on the long list, please get in touch. My email address, I'm sure, is on the various circulation things. has anybody got any questions or comments? Because I will take those now. I can't see any hands up.
I was just going to say, Siobhan, that thank you for your update, and we can include your email when we send the slides out. So if anybody does have any queries, then they can email you, get your email that way.
And I think it might also be useful for coming meetings to think about, you know, what would you like to hear from Healthwatch? What are the things that you would like us to cover in these updates? I don't want to come along and just bore people. And equally, you know, if there are things that we're not covering that you think we ought to be, I want to hear about that as well. I think Kate's got a hand up.
Hi, Siobhan. I just wondered, how does what you're doing locally in terms of priority setting chime with what Healthwatch England is doing?
So Healthwatch England have been undertaking their priority setting, and it's very much for us as local health watchers to define what our priorities are for local populations. We obviously, as part of the kind of the Healthwatch family, we're aware of what happens at Healthwatch England. And I think what's been different over the past year is that the priorities that we set as health watchers this time last year didn't proceed, and we followed the Healthwatch England priorities that were developed in response to COVID. I've been talking to Healthwatch colleagues around the region, and different health watchers are taking different approaches. So some are rolling forward their priorities from last year. Some are not undertaking their priority setting process in the same way as they have in previous years, and are still very much in kind of response mode and wanting to be fleet of foot and not tying themselves to priorities. The decision we've made within our health watchers really is that we want to look at the priorities. The Healthwatch England priorities for last year served a purpose, but it's about moving on and understanding what it is that we should be focusing over the next 12 months. And to do that, we need to talk to local people, we need to talk to local communities, we need to work with our committees as representatives of those communities, and making sure that we're responding in the right way and in a way that makes a difference and where we can make a difference.
Thanks. Can I just ask another question, which is, are you still recruiting volunteers, and what are your volunteers doing at the moment?
Yes, what a member of the team is, or a couple of members of the team have volunteering in their job descriptions, and they are looking at that as we speak. So some of our volunteers are doing befriending calls. We're also looking at how we might increase the pool, but also thinking about some of the local health watch have young volunteers, and they have a youth health watch. And it's something that since I started, I've asked the team to do a bit more work around and to think about. It kind of ties in with how we will respond to some of the place-based work that was alluded to in the previous presentation. And that is an ongoing thinking process at the moment, although I'm aware that we need to think fairly quickly so that we don't miss the boat. But if you've got people who you think might want to volunteer, Kate, let me know.
Will do.
Thanks.
That's great. Again, a really helpful update. Thanks, Siobhan. Any further questions before we move on with the agenda? We're coming at the end of this session. It's gone really quick today. It's been really useful, hasn't it? Lots of good conversation and questions. Oops, I didn't realise that slide was there. It wasn't in the pack I looked at.
We couldn't let you go, Chris, without trying to embarrass you a little bit. But I just wanted to jump in to say thank you so much for all of your help and support, and the fact that you've really worked hard to drive involvement and engagement up the agenda at a very senior level, and it has meant a lot. And I think I'm speaking on behalf of everybody who's plugged in today. Thank you very much, and enjoy your retirement.
I will, definitely will, and thank you for those very kind words. I do appreciate them. I do. I'll continue to drive this up the agenda until a week on Tuesday. It doesn't stop. I did warn CMT I'm not going to go without saying my piece and everything I do before I go, making sure my voice is not forgotten. Are there any questions generally that you want to pose for the CCG that we can try and answer today or bring back to a future meeting? Nothing. Okay, so I'll just go on to the next slide then, Lindsay. So the next meeting is the 12th of April. Julie will be chairing that meeting. And we are, as I said, aiming to have place-based breakout sessions in the future. So there'll be more focus on Newcastle and Gateshead in the middle of each of the meetings. But still, we are still a statutory CCG until the end of March 2022. So I need to understand the impact for the whole CCG as well as place-based. Next slide. So the usual, really, for me again, the plea to complete the survey monkey, please. It does make a difference to what we see and hear, and hopefully you can start to see that we've tried to address those issues. I wasn't mindful. We heard a number of acronyms earlier on today, but to try to jump in quick and explain them in the chat box so people weren't struggling with what it all meant. I think sometimes we forget as health professionals because we use it all the time. We need to be more mindful, and so it's not intentional. So hopefully you managed to understand all of that. And we sent out as usual a written summary out to everybody, and the recording, as I said earlier, will be on the website. So it's people who weren't able to join today can then watch that at their leisure. There's nothing else. I'll draw the meeting to a close there, and thank you for your good wishes. It's in the chat box. I appreciate them.
Thanks, Chris.
Thanks, everybody.
Take care.
Take
Bye.
care, everybody. Bye now.
Bye.